Hello, and you are very welcome to today's session of the Advocacy Exchange. Thank you immensely for making time to be with all of us today and for being a leader in the patient advocate space. My name is Brad Love. I'm a GRIT co-founder and your host this afternoon. As our first and important order of things, I'd like to point out and introduce our two ASL interpreters this afternoon, or today, I should say, excuse me, about time zones, Emily Cook and Mackenzie Belez. If you need ASL interpretation, just a reminder that you can hover over their pictures and pin them by clicking on the three blue dots. Otherwise, you are aware, of course, that the theme of our session today is patients are people, improving cultural competency to reduce healthcare disparities. And so we are very fortunate to have your voice in this dialogue today, in addition to our two esteemed panelists. As people are filing in and we're settling into this wonderful first TAE session of 2022, we do have a quick check-in that we'd like to do with you, a poll question, if we might. That's about your experiences and how you interact with your healthcare provider. So, if we may, we'll launch this quick poll question, which we'll read when you see it. How does your physician make you feel like a person and not a patient? You can see a number of options. You can choose multiple, such as it serves you with your experience. And we'll give it a minute as answers to that aggregate. In just a few minutes, I'll ask today's two panelists to introduce themselves, and we'll have the chance to spend some very important time together, as you know from the session description, to think about the essential nature of cultural competence and cultural humility and individualized care that makes such a drastic difference in people's opportunities for positive health outcomes. The kind of work that you do every day in your space, the kind of work that you seek to amplify as an advocate. And sharing some poll results, we see some interesting things, some bits to note if you can see this pop up. We see, most importantly, something to wonderfully praise, that about 2/3 of you noted that your provider makes space for you to ask open-ended questions. The most wonderful way to gather data. We often call those in patient outcome research doorknob questions, because it's kind of the one as the provider's leaving the room and turns around and says, what else would you like to ask? But at that point, it's perhaps a little late in the game because the visit is almost over. So it's wonderful that your 2/3 of your providers make space for that. Being a good listener, we also see at 68% as a noteworthy. And a quarter of you are noting that it's still a work in progress, as it is for all of us, no doubt about it, because we're human beings. But just thinking about encouraging a provider to be a good listener and focusing on open-ended questions are two essential things that a provider can do. We can also appreciate the humility in having a provider, as 34% of you noted, acknowledging not knowing the answers to some of the questions, because again, as we will talk about today, providers are also people. And so the importance to amplify that humanity comes into a key part of our conversation. So that said, thank you again for taking the time out of your busy day to be here with us and for all of the leadership work that you do. I'd like to ask, if I may, starting with Dr. Rachel Bond, our panelists for today, to take 3 to 4 minutes to introduce themselves. And so, Dr. Bond, may I ask you for a little bit of an introduction and your background and why this is a topic of importance to you?
Absolutely. I just first and foremost want to thank you, Brad, for moderating this session and for the organizers who have invited me. So my name is Dr. Rachel Marie Bond. I am a practicing cardiologist currently in Chandler, Arizona. With that realm, I work very closely with my healthcare institution on a lot of missions centered on both gender as well as race and ethnicity healthcare disparities. I'm our system director for our women's cardiovascular program, and most recently was appointed the assistant director of our diversity and inclusion program within our residency program that we're developing in Arizona. On a national level, I sit on several cardiovascular societies from the American College of Cardiology. I actually am on the Women in Cardiology leadership sector nationally, and I have several roles for the Association of Black Cardiologists, where most recently, I was also just brought into the board of directors for the ABC, and I also am the co-chair of the Women and Children's Committee for the Association of Black Cardiologists. So all of this is something that naturally has been a mission for myself since starting out in the healthcare field and the healthcare sector, where we know disparities in care exist, especially when it comes to cardiovascular disease, the leading cause of death in the United States, despite being preventable 80% of the time. So a lot of the work I do is focusing on marginalized communities and getting the messaging out there to those community members.
Wow. Thank you for taking the time to be with us today and for all of that work. There's so much to be enthusiastic about and praise and where you're putting your energies, particularly the way that you are creating systemic change by thinking about how medical education happens. And so that fits wonderfully with the kinds of systemic work this group of advocates is seeking to do globally. Sheila Thorne, may I ask you to take a few minutes to introduce yourself, and likewise, thank you very much for taking the time to be with us today.
Thank you, Brad, and thank you, Grit Health and Bristol Myers Squibb, for arranging for this unique and innovative platform for the esteemed healthcare professionals like Dr. Bond and others to be a part of this conversation. I've been doing multicultural healthcare marketing for the pharmaceutical industry for about 27 years. And I started out as a marketer with medical ad agencies, public relations agencies, and I segued into my own business in 2003. I'm president and CEO of the Multicultural Healthcare Marketing Group, and my team is all of color. Half of us are multilingual, and we focus on people of African, Hispanic, Latino, Asian, and Native American descent, and all that they need in terms of health care, as well as health information. I've worked in 5 countries on the ground in Latin America. I lived in London for 6 years and did multinational programs, and then started to really see the need for a voice for the patients who look like me. And so I segued and still do the marketing, but it has transitioned into cross-cultural education, or what some people call cultural competency training. I don't know how you get trained in culture, but it's more education. But in any event, enjoy that very much, and I've had the privilege of working with a number of healthcare professionals in terms of helping them to be more proficient about culture. This topic is important to me because I saw early on that even though the intent would be to help everyone live longer and a better life, I saw that the industry was missing some folks, especially people who looked like me, who didn't speak the language and came from where I come from. So I took it upon myself to really focus in on what I could do to help make the engagement with patients, the engagement with providers of color and those who are not of color, treating people of color, to do a better job. And so it's a privilege to have had that experience nationally and internationally to make sure that everyone has the opportunity to achieve optimal health.
Thank you immensely. And thank you for those decades of work. I don't think we're here today without your legacy. So thank you for being the driver that's brought us to the progress that we've had. I'd like to start, if I may, based on some things that I have heard you say, Dr. Bond, in thinking about the idea of health equity. And part of the premise here is the idea that if we're going to have a conversation about a key idea, such as health equity, when we're using those words, it's helpful to make sure we're talking about the same thing. So I'd like to ask you, if I may, Dr. Bond, to discuss a little bit how you think about health equity and the importance of using the same words in the same ways so we can have mutual understanding?
Absolutely. It's a perfect question, I think, to start this very robust conversation we'll be having over the next hour. So first and foremost, it's good to actually define what health equity is, because I think there are several people out in the community who get confused between equality, equity, etc. And when we think about health equity, we know that it's not only a fundamental right, but it's a human right. That being said, it's best achieved when every person has the opportunity to attain their health potential, and no one is disadvantaged from achieving it because of a social position or socially determined circumstances. I really believe the best way to define it would be an example, a most recent example with the at-home antigen COVID testing, right? Because that does highlight how programs, although having the best intentions, can still be affected by institutional lapses in health equity. So as an example, on the surface, we have a program that makes available testing to all. However, when you actually look and critically review it from a practical level, you see that how health equity actually comes into play. This program is providing free at-home testing kits for each residential address in the United States, which is a great example of equality, right? Equal number of testing to all. However, when you actually look at individual households, let's say a 2 or 4 family household, that may be adequate for them, but a multifamily or multi-generational household, that's probably not adequate. We also know that to make it adequate or more equitable, we really want to not only think about the number of tests based on the household size, but more importantly, think about the structural and medical vulnerable households. So those that have much more medical vulnerability are most likely at a higher risk of having COVID-19. So that would be the equitable thing to do. And I actually believe that we should move the needle even beyond focusing on health equity and think about justice. Because what is justice? An example of that would be free tests for all that's easily accessible to all risks that actually require the test. And when we think about it, health justice is actually the human right that must happen in order for us to see change in our healthcare sector. So it's also very important that we use the same language. So we, as a society of advocates and clinicians, providers, et cetera, are actually targeting these vulnerable patient populations and understanding what is equal, what is equitable, with the intent of, again, honing in and focusing at the core, which should be healthcare justice.
Really appreciate those ideas and the unfortunately timely example, but that is a great way to help us understand and start from the same place. Sheila, may I pose the same question to you about how you think about health equity and the importance of using the same words in the same ways for understanding?
I'm going to pick up on something Dr. Bond said, which is really my definition, and that's social justice. Clearly, when we talk about health equity, we use the words like striving and pursuing because it's something that we have not yet achieved. But in the process of doing that, we really need to intertwine health disparities with that, because health disparities are the metrics to show whether we have achieved health equity. So you've got to know exactly what are the gaps in terms of how people are living with chronic disease or terminal disease. So health equity helps us to understand what people's rights are, that they have the human right to live a quality life, to get the best healthcare, the opportunity to get the best healthcare. So you can't separate the two. The disparities show us how far we've come. Health equity is an aspiration, but we clearly know that it has to be a part of the mix. Brad, I learned early on that advocacy had to become a part of what I do because of the populations that I was targeting, because they needed a voice. They didn't have one. They weren't invited to the table. And the healthcare industry definitely had a cultural deficit. They didn't know how to reach these groups. And even if they did know how, they didn't do it. So they were reluctant, they were resistant in terms of making sure that they were inclusive. Now we're in an age where that exclusivity is hurting us as a community and as a country. And certainly we need to have health equity a part of our goals. It seems elusive, but because social justice is a part of it, it takes more people at the table to achieve it. So disparities are the differences in outcome and the differences in status. Equity is what we hope by closing the gap on disparities we can achieve. justice, social justice, civil rights.
Thank you, Sheila. There's a lot to love in there, and so much that's exactly critical to our advocates today as they're seeking, as you would put it, justice and equity and the outcomes for people who exist in their communities. And so this is a great start for us to be thinking about understanding each other's journeys and ultimately, as we'll get to toward the end of the conversation, some potential ways forward. I would like it though if we could dig in a little bit to some of the barriers that we are dealing with, some of the reasons that equity is aspirational, as you mentioned, Sheila. And so starting with you, if I might, I was wondering if you could outline a few of the barriers that you see toward real progress in justice and equity.
Probably one of the most significant barriers is trust. Whenever you talk about communities of color, the trust issue rears its head all the time. Historically, these groups have not been treated very well. Medical abuse, discrimination, prejudice, racism have entered into the mix. And unfortunately, because of that, the trust has been eroded about what these populations can depend upon. The trust is a firm belief that you can be confident that something is going to happen. Mistrust is what we've experienced over the decades, the centuries, that these populations have tried to get the appropriate health care. Suspicious. We don't have confidence in the people who are delivering the care because they don't look like us. They don't sound like us. And they don't apparently seem to have our best intentions at heart. So that mistrust is always there. The distrust, I believe, is another nuanced understanding, because that means I did trust you and then you disappointed me. Okay, you showed me that you really weren't interested in me because your information wasn't good, it wasn't up to date, you mistreated me, you dismissed me, you didn't listen to me. So they're similar but different. And with people of color, that issue comes up with getting a vaccination, getting in a clinical trial, going to the doctor at the first sign of trouble rather than late diagnosis, which is more expensive and harder to treat. And that helps, that prevents us from achieving our optimal care. And the distrust is that when we do get information, it's not culturally competent. It's not appropriate. It doesn't resonate with what I was raised to think and believe about health. So that really enters into the prominent barrier that hinders and prevents and jeopardizes people of color getting that quality health. So if we can get that trust, which is a process, you have to earn it. It takes time, and it takes being confident that my doctor, my healthcare facility is going to be consistent in their care, no matter what door I enter and what disease I have. It takes time, but once you earn it, you've got to keep building on it so that distrust doesn't enter into the dialogue.
That is such a constructive lens to breaking down the situations that healthcare providers and patients and advocates can often be in, to understand the complexities that might be individual and interpersonal, where some degree of distrust develops, but also legacy issues, the historical things that you mentioned. And then maybe most importantly, the fact that, as you concluded, it's active to maintain trust. You have to earn it every day, as we do in many of our environments. But that's a great conversation for advocates to have within their domains, to think about perhaps as they share with their communities, what does it mean to earn trust within those spaces? What are the reasons people in each of your communities as advocates might have degrees of mistrust or distrust? And how can one counter that? That's a great bit of homework for everybody, Sheila. Thank you for bringing that up, because that's a place where people can take action. Each of our 105 attendees can do that within their spaces. Dr. Bond, if I might turn the same question to you, what do you see as the barriers in pursuing health equity and making sure patients are received as people?
Yeah, no, I think just piggybacking off of what Sheila very nicely stated, cultural competency is a big factor and a key factor. As it stands, we have vulnerable patient populations that are coming into a very flawed healthcare system, a system that for the most part doesn't look like them nor identify as them. And I think that that is the largest obstacle, that we still today in 2022 have a very low abundance of physicians of color or clinicians of color, or even to that same degree, when we think about patient provider concordance, data has clearly demonstrated that when you identify with your provider, you're more likely to have better outcomes. But more importantly, we know that data has demonstrated when you're working in a very diverse healthcare sector and force, you as well will have better outcomes because you'll be more thoughtful, more empathetic to these culturally different patient populations. To that same point, though, when we think about trust, what I will tell you is that there are challenges, right? So there's challenges even from a clinician level, because although we want to take the time to provide and allow for that patient provider communication to develop that trust, right? Just like any relationship, we need time to grow that. As it stands right now in the healthcare system, it's very challenging and limited at times for doctors to actually have the time to sit and converse with the patients one-on-one, not just physicians, but also any provider or clinician. And I think that at the big portion of it is what's going on in the healthcare field and the healthcare sector, that a lot of it puts a lot of administrative responsibilities, removing the doctor from actually having that one-on-one human touch and human contact with the patient. And I think until that changes, it's going to be very challenging to have that degree of trust. What we have to do is definitely make sure that we provide the time, and it may not be on the first meeting. What I always recommend and suggest to patients is that they come prepared. Just like when you go for your taxes, as an example, you come with a series of questions for your accountant. You should be doing the same for the doctor, for the clinician. So that way it's a more thoughtful conversation where you can focus in on what your concerns are and grow that trust and get rid of the nuances that may arise, such as the paperwork of filling out the forms when you're in the doctor's office, et cetera, et cetera. And I think until we really collectively change the system, we're going to have to get around the system by really providing key sound thoughts about, well, maybe we should come prepared to the doctor's office. But more importantly, I will say from even as early on as medical school, we're now trying to revamp the curriculum to allow our medical students to better understand that we need to develop a relationship with our patients before we start instructing them on what we believe is best for them. We really need to include them in that conversation. And I really think that's where advocacy missions like this and all that the work that everybody on the call is doing is really key and impactful, because it gives the patient the voice, but more importantly, it allows the patient to identify the healthcare provider who's willing to listen to them. And I think that's the most important thing, you having the voice, but having a clinician who's actually willing to listen to you and take the time, more importantly, to listen to you as well.
Yes, no doubt about it, as I just put in the chat, because I think it's such an impactful, powerful tip, is within each of the advocate spaces represented here, coming up with a list of essential questions, maybe before someone's first visit or treatment about diagnosis X or situation X. Could be something that we could share amongst ourselves and help people come in prepared, particularly at a moment in life when perhaps brain space is at a bit of a premium because they're negotiating something challenging. And so that's a great bit of wisdom. Thank you very much for sharing that.
Brad, can I add one comment, please?
Please do. You have all the comments you want.
And Dr. Bond picked up on it very nicely, the cultural competency piece. If you're a marketer, if you're an advocate, and you don't look like the populations you're trying to engage, you need a partner. You need somebody to walk in the door with you. So that enhances your credibility and hopefully gets you on that path of trust. They may not know Lottie Robinson, but they may know Sheila Thorne. And so when we walk into the room together, that helps the patient understand that your information is coming from a source that's sensitive, that's empathetic, that is competent. So as advocates, we need to really understand that. Who are the right community partners, the messengers, the credible partners who can sustain the interest of that patient with their doctor and encourage them, motivate them to get into treatment if needed, stay into treatment, and to share the decision-making with their healthcare provider. So it's a collaborative effort, and it takes all those. I mean, we want more people of color in healthcare, but until that happens, we have to partner.
Yeah, excellent point as ever, Sheila. Thank you for sharing that. If I might ask you to build upon that a little bit to help inform some of our attendees today a little bit about some of the complexities of those situations. Could I ask you to share a little bit about the ways that social determinants influence those not only ultimate health outcomes as we talk about in public health, but clinical visits and the way that everything happens really in the healthcare system? So if I may, could I ask you to share a little bit about your understanding and experience of the impact of social determinants as a barrier?
It's long overdue for the consideration of social determinants to be part of the mix. And we know that those determinants are better predictors of outcome and status than having that insurance card. People always look to socioeconomic, well, you don't have insurance and you're poor. Well, okay, we can't fix that. However, the reasons for those things are based in the social determinants. Do I have transportation to get to my doctor's appointment or to the clinic? Even before that, have I have access to healthy fruit and vegetables to eat so that at least my system is in a better position to have treatment that will work? Do I have a job? Do I feel safe in my community? If I need to exercise, can I walk around and feel comfortable? And health literacy, do I really understand what it means to have diabetes or to hypertension? All of those things are in the mix that if we don't recognize them, we'll lose patients because we'll see that they are not capable and have the ability to take advantage of health services and health products. It's not that I don't want to go to the doctor. I just don't have the bus fare. I don't have a car. And are there resources in the community that as a healthcare organization, you can offer to the patient to say, here's something that might be helpful to you, not specifically because you're Black, but because everybody should have that sheet of paper. You know, what are the options for travel? Where can you get good food, healthy food on a regular basis? Those social determinants are key. And one of the determinants that have been added to that list are racism and discrimination. You know, how do you help your patient be empowered to exactly overcome that barrier? It's systemic, it's institutional, it's structural. You can't escape it, but that can't be the excuse for not achieving optimal care. It's demanding quality care and knowing what that is. Social determinants are key factors that we certainly as advocates and marketers can put into the mix.
Thank you immensely. And the ways that your response and the kinds of things you think about and work on in social determinants are so essential at understanding where the real barriers are. Because as you say, the transportation, if we think about that, no matter where you are in the world, it can be a real complex endeavor. Dr. Bond, if I might turn the same question over to you, how do you see social determinants as a challenge as a practitioner?
Yeah, I think I love what Sheila mentioned in that it's regardless of socioeconomic status. Yes, socioeconomic status is part of these social determinants, but it's not the end all. And I think a really great example of this is what we're seeing with the Black maternal health crisis. As it stands now in the United States, we are the only developed country that is having rising rates of death during pregnancy and immediately after postpartum, and it's disproportionately affecting Black women. Heart disease is the leading cause of that, so I do a lot of work in this sector with the organizations that I mentioned. But we know that education, income does not protect these women. We know that the mere fact that they're Black women in America, they are at a much greater risk of dying during their pregnancy and immediately after their delivery. And I think, as Sheila very nicely mentioned, the core around that and centralized theme of that is the social aspects of that race. So the racism that's coming from the structural, the institutional, and things that we, I think, are, as a society, we obviously have to acknowledge our biases, be it conscious or unconscious, that we may have. But beyond that, we need to also empower our patients to understand that because of how they look, they are starting out at probably a little bit of a disadvantage because of the system. It's just the way that the system has been built. And what I will tell you is that many people don't understand this, but they really believe that health is more impacted by our genetics and biology. And we know that that has been disproven. Nearly 80% of our health is impacted by these social determinants, these key factors. So starting off with patients of color, why are we seeing higher amounts of chronic medical conditions? Well, because of these social aspects. And I think until we as a society work on figuring out how we're going to get to the core, which is that racism, we're going to still see it. But as Sheila very nicely mentioned, we still have to bring it to the mention. We have to bring it to the forefront. And we as advocates have to work together on how we can piece by piece work to actually mitigate this, right? Little baby steps will lead to, I truly believe, a larger goal, which is removing all of the disparities that we're seeing in this sector.
And Dr. Bond, isn't it true that we say that it's not your genetic code, but it's your zip code that determines your health? Where do you live? And as marketers, we have to include that component as we're designing campaigns, so that where that person is, how accessible healthcare facilities are, is really going to determine how involved they get in taking charge and control of their own health. It's those external factors and forces. And isn't it true, Dr. Bond? Being Black is a risk factor for many diseases. So clearly, you know, you really have to put that race and ethnic component in the mix so that it's not one size fits all. It's got to be tailored and customized so that the person sees that they can take charge of their health.
Absolutely. And to that point, I think just in race in particular and ethnicity, it's really when we over rely on the genetics of it where we begin to see these flaws, because it's, again, the more social portion of that race and ethnicity leading back to those social determinants of health. But without a doubt, our communities of color have to understand that the mere fact that they are Black or brown in America, they're at a much greater risk of having poor outcomes and ongoing chronic medical conditions.
We saw that with COVID-19, didn't we? Underlying conditions, obesity, diabetes, respiratory disease. Well, you know, they just don't take care of themselves. They started blaming the victim rather than the system. How did they get to be that way? What forces shaped that so that diet was not controlled or medication wasn't taken? So, you know, again, you've got to go to the root cause, and the root cause of the systemic complexities of care and how it's delivered or not in this country.
Agreed, and globally, you know, we're speaking largely at the moment from a US-centric context, but obviously many of these challenges exist across nations for sure, and within nations and within cultures with their own histories. And so it's a particular human challenge, to say the least. With the time that we have, I'd like to see if we could orient the conversation a little bit to think about moving forward, to think about what each of you, for example, have been doing, but also the advocates who are with us today to help counter some of these challenges that we've been discussing, to help counter and improve, obviously, issues of health equity. And so there's a lot for sure that you two have each been doing for quite some time, and for advocates, and we'll ask to hear from those advocates in just a few minutes. But to start with you, Dr. Bond, could you share a little bit about the things that you've been working on and how you're thinking about what moving forward and improving these outcomes looks like?
Absolutely. So a key factor that I've been working on, as I made mention of, is when it comes to the United States in particular, we see that we do not have a very diverse clinician workforce that looks like me or identifies as me. One thing that I've been working on with a lot of the societies and even within my own local institution is to increase the pipeline to the medical field. We have to diversify the field of medicine. So we make sure that the patients in our community are reflected in those that are caring for them. Beyond that, though, we want to provide cultural competence. We want to make sure that everyone, irrespective of their race, gender, creed, et cetera, understand not only the historical context of why there may be components of mistrust or distrust, but also have the tools to navigate or best navigate these particular situations. So again, a lot of that is being worked at both my local institution, but more broadly with the cardiovascular societies that I sit on and have leadership roles on. Beyond that, I would say that a key factor is also making sure we have access to healthcare. And as I had already made mention of, a lot of the work that I'm focusing on is centered on particularly gender disparities, especially centered on the maternal mortality crisis that we're seeing. And we know that not having seamless follow through and even insurance, healthcare insurance is a key factor as to why we're seeing a lot of the disparities and a lot of the despairing numbers and rising numbers in particular patient populations. So from an advocacy perspective, through a lot of the national organizations that I sit on, we are working with leadership and politicians to try to make sure that we push forward the importance of extending, even as an example, Medicaid coverage, something that really, again, should be a human right, but the vast majority of the time is not happening and we're not seeing in our most vulnerable patient populations.
And the same for you, Sheila, please. How do you see ways forward?
Yeah, I see the need for education being a primary strategy that I've been focusing on more. Most of the healthcare professionals I've had the privilege of working with get it philosophically. They understand the why, that we have to change and what we should be doing. They don't know the how. They don't understand that building those relationships takes time. Identifying key credible messengers, it takes time. Just because you are of color doesn't mean that you're the right messenger. So I think it's the bottom line. Where most people fall, Brad, is they don't know what they don't know about these populations. And when they do get that sense, then they can shape and customize their programs accordingly. So I spend a lot of time talking to healthcare professionals about what they need to know. They're very receptive. They clearly do want to do the right thing. They just don't know how. And so for the benefit of those of us who've been doing this a long time, then we can share with them best practices, things you should always do, things you should never do, things that you should do if you have the time and money. So clearly there's a continuum. Anybody can jump in and own something so that they are part of the incremental change that needs to happen. And if everybody does that, it's good for all of us. I think back to a document that I shared with many people in this forum, the Healthy People 2010, Healthy People 2020. These are the 10-year markers that the government uses for health promotion and disease prevention. It was eliminate disparities. Next time it was reduce disparities. Now it's justice and equity in healthcare. It's changed. They're heading into that social justice arena and the civil rights concept. The book, Dr. Bond, I'm sure you know, Unequal Treatment, Addressing Racial and Ethnic Disparities in Health. That term unequal treatment is in the civil rights legislation, okay? They've now applied it to healthcare. So this is not just a nice thing to do anymore. It's something that you must do if we're ever going to achieve health equity. So to me, my role as a cross-cultural educator is going to be key to helping build that foundation for not why you do, what you do, and how you do it. I often tell people, Brad, I taught middle school for 7 years. I'm still teaching. The kids are just bigger. So it's important, and we all have something to learn. And there's no silver bullet here. There's no magic answer. We unfortunately in this country have not been exposed to the education we need about these various groups. It's been suppressed. So clearly we've got to open our minds, start doing some reading, start understanding the dynamics so that understanding these culture is based on information that we can trust. So that's my contribution, education.
I appreciate that. And I'd love to keep going on that theme, if we might, to really serve the advocates who are with us today. and if I might come back to you, Dr. Bond, to ask for a few pieces of advice, a few things our advocates can take with them today to think about at least small steps to help move forward. So, for example, what does it look like to promote, from their perspective, a quality clinical encounter? What does it look like to learn about or teach their memberships, communities about culturally humble, culturally relevant care or anti-bias work? Just a few tips based on your experience as you've been leading so many spaces in this area.
Absolutely. Well, I think the most important thing, as you mentioned, Brad, is to make sure that the patients do feel empowered, that they can come and should come prepared when they speak with their clinicians. So one way to do that, as I alluded to, is coming in with questions, possibly even thinking about bringing another set of eyes and ears, right? So a partner who could actually ask the questions that they may forget, or hear what that clinician has to say because they may be overwhelmed in that moment. So having a partner in crime, even if it's somebody that's not a family member, but somebody that's a social support system for them, I do think would be key and is highly encouraged. Beyond that, I would say that we want to make sure that each and every individual person that we come into encounter with in the healthcare field, we ask them to look within themselves for their own biases that they may experience. We all have it, as Sheila very nicely mentioned. Even those people of color experience biases within our own communities. And we know that in order for us to acknowledge and care for these vulnerable and marginalized patient populations, each and every day we have to ask ourselves, is there a bias within myself? And if there is, what can I do to change that? I think the change won't happen unless we actually ask ourselves that question. I know I do it every time I sit down with the patient. I ask if there was something I could have done better. Was there something I should have asked? Was there something I was missing because I wasn't listening to what they were truly trying to tell me? And I think if we pause and take a second with each patient encounter, will go a long way in not only reaching and understanding truly what the patients are intending for us to hear, but more importantly, we will build that trust that we definitely see we're lacking in our healthcare system. So those are the tips that I would probably suggest to the audience.
We appreciate that very much. Sheila, may I turn the same question for you to just crystallize? You've already been sharing, of course, wisdom about ways forward, but to help, as you can understand, as a former teacher and current teacher, a little bit of repetition helps us in our brains. So what tips would you offer?
Well, I'm going to pick up on something Dr. Bond said, is that including other people in the process of decision making. I just made that suggestion to a group that was struggling with, should I be in this clinical trial? And she brought a pastor with her. She brought her own spiritual advisor to listen in on the conversation because she was overwhelmed with it and would miss things. So I think that's important to know that the family, the community, and communities of color is extremely important. We don't often in these groups understand that I don't make an individual decision. I look for others to help me, to support me, to make me feel that I'm safe in making whatever decision it is. So that's one tip. Include the family, the caregivers, the caretakers. They may not be blood relatives, but they are people that are trusted entities that would need to be a part of the conversation. A disease doesn't exist in a vacuum. It exists in a social, cultural, family context. So everybody's going to be affected. So everybody should be brought into the mix. And you used another phrase, Brad, cultural humility. That's key. Very hard for very well-educated, sophisticated healthcare professionals to go to that level, but your way is not the only way. You've got to appreciate there are differences, and you may not understand them, you may not like them, but you must respect them and address them. Otherwise, the patient will come to you for your clinical competence. They'll come back if you're culturally competent. So if that's what you got into medicine to do, then you've got to embrace cultural competence as a key skill in order to keep that patient coming. You know what the expression is? I don't care how much you know until I know how much you care. So you've really got to make sure you have that relationship based on an understanding and a give and take. So many Black people tell me they're dismissed by their healthcare professionals. They're being overly dramatic, or they're hypersensitive, or they're, you know, clearly not part of the a good feeling in a clinical encounter. Don't dismiss us because you assume things about us because of the way we look. Listen, question, engage, and be open for difference.
Thank you. I'd like to build on that a little bit. And Jacqueline in the chat has started a wonderful thing. So thank you, Jacqueline. My question to our 100+ attendees, our 100+ leaders who are with us today, is building upon what our panelists have shared. Could I ask you, each of you in the chat, to share what you do in this space? What does better, more equitable care look like in your advocacy space? What tip are you going to take away right now? Help us see what you're thinking and understand how you're going to move forward from this session. Jacqueline shared signing up with a patient health portal so that people can review their own reports and have agency over their data. What else will you take away in your spaces? We'll give it a minute for people to type and share how you're going to pursue equity within your spaces. There are many things to think about in the ways that information, being culturally relevant, social determinants, all come into play in how people access care. And then I'm going to do the teacher thing and be quiet for a minute. I love this idea, Greg, for sure. Educational materials with universal patient language to work on challenges of health literacy, no doubt about it, and think about cultural and geographical nuances. That's a fantastic tip for every advocate, for sure. And yes, Morgan, you are a generous, generous community member here and elsewhere, providing service without judgment and compassion. No doubt about it. Okay, Jacqueline, another fantastic tip. Yeah, recording the office conversation, no doubt, right? To help us transcribe, look for key terms, understand how the provider offers relationships between A, B, C, and D, and so on, to better understand or share with others. You know, Sheila's fantastic point about it that Dr. Bond mentioned as well, of course, about bringing someone with you. And the office visit conversation helps us share that more broadly. Yeah. Fantastic. Thank you, Jean. Cultural humility. Yeah. Asking what I don't know. Yeah. Thinking about the trust, distrust, mistrust conversation from earlier, just the simple idea of asking what I don't know in this situation is such a powerful relationship builder. I mean, it just makes things so human, doesn't it? Appreciate Tracy, the platform for MDS patients to share stories and identify disparities. It's a great idea from the community directly. That's right. No assumptions. Yeah. Fantastic. Love it. Liz Wolfe, as always, thinking about resources and programs with equity as a foundational component. Great, Andrea. Yeah, being open-minded. Yeah. Yeah, and you know, Jen Sertle, as you're pointing out, some of the ways we have to challenge ourselves, right? Where Jen, as you're saying, you know, going it alone is what is taught in a lot of environments. And we take a family as a cultural unit too. They have their own cultures, right? Any sort of group of loved ones for sure, and sometimes challenging that. Yeah, fantastic. And Morgan, as you say, right, that you can't want an outcome for a participant more than the person does. Yeah. Yeah. Serve the person, not our own expectations, right? Okay. Love it, Jacqueline. Exactly. A list of questions in your cell phone notes, which is something, just thinking about the list of questions for each area, for each community that each of you represents, that's something you're uniquely situated to do. And to think about how to ask those questions in a culturally appropriate way, in a geographically, in a health system appropriate way, as the case might be. But to share those and save other people the intellectual, the cognitive labor at a moment when they just don't have that much to go on. Okay. Shubhra, thank you. Addressing information asymmetry, yeah, including different groups for awareness and access. Okay. Sarthak, love this point about following up with the patient and the caregiver after appointments so that people have had time to process. So very essential. Okay. Wonderful sharing, everyone. Thank you for your willingness to take some collective action at putting wisdom in the world. No doubt about it. This is a great way to go. And this is our objective at being together on days like this, to share experiences, to find the linkages, to understand that many of the challenges advocates face, regardless of the community's focus or geography or whatever, there are similarities. And so there's a lot to share in supporting each other and helping people expedite their own journeys, because it may be steps you've already taken and you can tell them how to get there. And so there's certainly so much to do in that space. We appreciate all of you sharing that, no doubt. If I may, for a minute, come back to our panelists, just to ask, what are you taking away from our conversation today? What's the top of mind thought on your brain after spending some time in community with our advocacy exchange and with each other? I know I just put you on the spot, but I'm very, very confident this is going to work out great. What's top of mind for you right now? Please, Dr. Bond.
Sure. So, I mean, I think the top of the mind is that I am encouraged by our conversation, and I'm actually more and so encouraged by the panel, those that participate, the participants, and the comments that they have included in the chat box, because they're all comments that I think if we continue to get the messaging out there and reach out to the masses of the community, we will actually see the changes that we're striving for. I'm encouraged to continue to do the work that I'm doing, and I'm honored to be in the same room and panel with such wonderful community leaders as Sheila, as an example, who's really working at the forefront to get education out there. And I think, as you mentioned, being a teacher never ends. It's something even for myself, I was thinking about becoming a teacher versus a physician. I decided to go into medicine, being the first physician, medical doctor, I should say, in my family. However, what I've learned in being a doctor is that I also have an opportunity to teach. So I teach my residents, my medical students, but more importantly, I teach my patients and I teach my colleagues. I teach my colleagues on how to look within themselves and understand the biases that they see and actually demonstrate the key structural biases that we see as a whole. But I'm encouraged today by this discussion. And again, I thank those that have listened in for the last 45 minutes to 60 minutes or so, because it's definitely giving me the uplift on a Thursday early morning here in Arizona to actually continue to do the good fight of what we want to do, which is, again, remove these disparities in care that we see. So thank you.
I'm going to continue with David Craig's comment in the chat about how long we've been doing this. You know, there have been benchmarks of success along the way, and COVID-19 catapulted us into this whole discussion about equity and disparities like never before. The murder of George Floyd got a global response. So people are really at the table willing to talk about something that they were hesitant to talk about maybe a decade ago. So in my view, I use the words of Dr. Martin Luther King, whose birthday we just celebrated, is a fierce urgency of now. You know, it's the time to do this. It's a watershed moment. It's a pivotal moment when people are opening their doors, hopefully opening their minds to see that there's a different way to do something, and that the health of individual groups means the health of all of us. in one way or another. So I hope what I take away from this is also encouragement, Dr. Bond, that they're now talking about something that they shied away from long ago. And I think that's the key component for advocates, self-advocates, professionals, marketers. All of us need to be at the table because it's in the collective experience that we're going to solve the problems. It's complex, it's systemic, it's not any one group. The pharmaceutical company can't do it alone, advocates can't do it alone, physicians. So we've got to be willing to be collaborative in our efforts. But in my view, this session, the time is now.
Thank you both immensely. The time is indeed now. We are here for collective action. We're lucky to have leaders like the both of you and the 100+ other leaders who are with us today. Thank you all for being part of this progress. Your willingness to share your lessons learned, to support each other, to be part of this dialogue and find ways forward amongst, Sheila, as you pointed out, incredibly complex challenges. There's a lot to admire and a lot to praise in that. So thank you all for investing the time today. I'd like to make one quick reminder that February 3rd at 11 o'clock Eastern Time US is our next session. The theme being assertiveness is not aggression, accessible strategies to advocate for quality care. This is something advocates experience and know well. It's the definition of it. And so the theme of that session and the content of that session is about learning how to make those challenging asks and how to move things forward within your spaces. The last thing I would like to point out is, as the meeting closes today, a short survey is going to pop up that will help us understand a little bit about what each of you took away from today's session and your feeling of empowerment in working with your provider so that we can understand the utility and impact. So please do complete that survey. That said, I'm going to put up my applause emoji for our panelists today, and without clapping too loud, do that. So please, I encourage you to use your applause emoji as well and thank them very much for sharing their time and expertise as we finish up a couple minutes before the hour so that you all have the opportunity to stand up, take in a little bit the wonderful wisdom that we've shared, and fill up your water containers as you move on through the Zoom day. So thank you all again. We look forward to seeing you on February 3rd. And we thank again our wonderful panelists for sharing their multitude of experiences.
Thank you. Have a great day.
Thank you so much.